Deepa, and welcome to
Yeah,
this
good.
live.
Yeah,
So
thank
I was
you.
singing your praises busily. Did you hear any of it?
No, I think I was just trying to figure around how to get into the stream, to be frank. Yeah. I'm too
Okay.
good with these the
Yeah,
technology
yeah.
stuff. Yeah.
Yes, yes.
Yeah,
So let us just dive into the conversation. So
sure.
why did you choose neonatal intensive care?
So, always I knew that, I want to do something which is close to being with kids. I think if I was not a doctor, probably you would have found me somewhere in a kindergarten or a play school. So, it's my love for kids is what, I got into pediatrics and, babies in particular. And that's the reason that I had chosen neonatology as my main subject and of specialization.
That's nice. But I can imagine how stressful it is. So how do you actually ground yourself? How do you make some space for yourself, in the stress of everyday NICU life?
Yes, so it is really stressful, but it's the passion for neonatology and the work that we do and the outcomes that we get when we see these, tiny babies who are just 500, 600 grams and seeing them happy and go home with their parents. That is what basically drives us. But it is a lot of hard work and it is
Yeah.
challenging. It takes away a lot of your personal time. Basically, you don't have a work-life balance in this field, but that is what keeps us going. So only when you're driven and you have a passion for this subject should somebody get into the neonatal intensive care field of work. Yeah.
That makes a lot of sense. So, why is it that we need to be aware about preterm births? What it is, and what is it about prematurity that makes it very risky for babies?
Yeah, so basically, preterm babies, we know these are babies who are born before 37 weeks of gestation. And when it comes to preterm birth, there are certain risk factors which can lead to preterm birth in general. So, this is if we are getting, say, a conception is through an IVF, or if there is a twin or a triplet pregnancy, if the mother is, say, a little bit on the younger, this thing like a teenage pregnancy or a little elderly, or if there are issues with, the cervical incompetence. These are common reasons why there could be a preterm birth. Now, why do we so much emphasize on this is because if the baby comes out early before 9 months completed gestation, there could be a lot of complications. So, in general, what everybody talks about is just the breathing concerns that the baby may sometimes need some sort of a breathing support. There could be a long stay in the NICU where everybody expects that, we have a good, healthy baby and go home with a 2.5, 3 kg birth weight and go home second, third day after delivery. But this doesn't happen in case of a preterm birth, which is most of the times, we do not anticipate it. And
Yeah.
so the whole plan, the whole, idea about pregnancy, delivering, getting a baby changes. And all of a sudden you have a baby who's in the ICU and, so many procedures on the baby. And you never expect the baby to have a long stay in the hospital, which, suddenly these new things are forced upon you and you suddenly have to listen to all of these medical terms which you were not at all prepared for. But this is a reality, and we are seeing more of preterm births, especially with use of artificial reproductive techniques or
Yeah.
assisted reproductive techniques, and that's why this is a
Hmm.
reality. And I think most of us need to be more and more aware about it. However, this is nothing that we need to be scared of. Based on how small the baby is or how early the baby is delivered, the outcome may change, and the duration in the NICU may change. So it's not that bad, but some babies who are born early, we may need a lot of support. Say if it is less than 28, less than 28 weeker, or if the birth weight is somewhere less than 600 grams, then you are thinking of a really long duration of stay in the NICU. So based on how early the baby is born, the duration of stay in the ICU would change.
Okay. So it's not that every baby who's born preterm has to go to the NICU. That is not a given.
No, that is not a given. So, not all babies come to the NICU. Generally, we see that babies less than 35 weeks and
Okay.
less than 2 kgs would require some sort of a support. But every baby is different. You may have a
Yeah.
2.4 kg baby born at 36 weeks but has breathing issues. So
Mm,
there's nothing fixed. So every baby who's born, we need to assess at delivery
yeah.
and see the situation and decide whether the baby requires to stay in the NICU
Yeah.
or can be next to the mother.
Okay. So, for the purpose of this conversation, let's just assume there's, say, a mother who's in labor at 26 weeks,
Yeah,
and they've notified you about this.
yeah.
So, let me know firstly, what are the thoughts in your head? Secondly, how do you prep your team? Thirdly, how would you talk to the pregnant parents in this scenario?
Sure. So, when it is a 26-weeker baby that is expected to deliver, we need to know that the baby is going to be, of a weight around 1 kg or less. And that is why the baby would require to stay in the NICU for at least around 8 weeks is minimum. So what I would prep the parents first is that you need to, start making up your mind that the baby is not going to come to you in 2 or 3 days, but the baby would be staying in the NICU for a longer time. Now, what are the issues that we would expect in such a baby is that the baby can have issues with breathing. So, this sort of a baby who's born so early, that is around 6.5 months of gestation, would require a lot of breathing support. So, generally, this baby would be ventilated at birth. So these babies have lungs which are immature, and there is a substance which is called a surfactant which is deficient in their lungs. And therefore, these babies would require respiratory support. So these babies may need this medication to be put into the lungs. And also, based on how the baby does in the first couple of days, we can decide whether we need to continue to ventilate the baby or we can switch to lesser invasive forms of breathing or ventilation, which is called as CPAP or high flow oxygen. So these are the other ways the baby can be supported. But looking at a 26-weeker, in general, the baby would require ventilation in the beginning. Now, there are other
Okay.
issues which we will also have to face in the NICU, and that would be the baby can have infection. So, this has to be dealt with. Secondly, the baby can also have issues with the heart. So, the way the lungs are immature, all organs are immature, right? So, we're going to have, say, the blood pressure could be low in the first 2, 3 days. We could have other structural issues as the baby is preterm. Similarly, with the gut, now the intestine, stomach, everything is also immature. So the baby may have issues with digestion. The baby may have issues to, start feeding immediately. That wouldn't happen. So what we
Yeah.
need to do is we need to, start with a little bit of nutrition given through the IV lines, where we put in some lines into the baby, where we give nutrition in the form of glucose, we give some protein, we give some fat, along with vitamins and minerals. And then slowly, gradually, feeds are introduced for the baby. So
Okay.
this is how, in general, about nutrition that the baby would be taken care of. Gradually, the baby would be started on tube feeds, wherein there is a tube put in from the mouth to the baby's stomach, and this would help the baby to start getting milk. As at this gestation, at 26 weeks, the baby will not be able to even swallow milk. So
Yeah.
the baby would not be able to suck, swallow at the breast at all. So you need to start giving feeds through the tube, then gradually introduce a little bit of oral feed somewhere around 32 weeks of gestation. By about 34 weeks, somewhere 32 to 34 weeks, the baby learns to even, have oral feeding and also do a little bit of direct feeds. So it
Okay.
takes a little while for the baby to establish oral feeds. So this is in general that we anticipate the complications. There are other issues which is, dependent on each baby, and which is more a detailed conversation. I don't think we should be going into those things as of now. But this is in
Yeah.
general the common things that we discuss. Now, when it comes to preparation for a birth, we always want that these are high risk deliveries. So
Yeah.
we always want one neonatologist with a team of doctors to be available for the delivery. So one consultant and junior doctors should be available for the delivery. The nurses should be all trained. We should have certain equipment which is required for, stabilizing these babies at birth. It should all be ready, and you should be prepared because these deliveries can happen anytime. So the
Yeah.
hospital has to be ready for these kind of births. Now, for the temperature, these babies have to be transferred from the labor ward into the ICU by incubator, which will provide a similar environment like how the baby is in the mother's womb. So
Okay.
all of this would require certain equipment, would require the team to have some expertise in handling this sort of a birth. Also, it is important that to help with the lung maturity, that the mother should be given antenatal corticosteroid
Yeah.
injection. So this is in general that we discuss with the gynecologist and ensure that this is done, unless it's just an emergency delivery and the baby just comes in and no gives us no time. Also, there is nowadays that we use magnesium sulfate, which is helpful for baby's brain protection, and this is also recommended just before delivery.
Okay. So it's quite comprehensive what you need to be prepared for and what you need to tell the parents.
Yes.
So, all these years of meeting preterm parents and counseling them, what is the common, the doubt they have when you're telling them all this? What is it that they generally tend to ask you?
Yeah, so see, because in India, these facilities for handling such a small baby is available only in private institutions. So the main concern what comes up with such a long stay is how to fund this sort of
Yeah.
ICU stay. So mainly parents, even though they may have some sort of an insurance cover, but it is generally not sufficient. So
Yeah.
that is the reason that they start stressing because of the long duration of stay. Now, in spite of doing all of this, some parents are also worried because the baby, even after paying through the nose for the bills and for such a long stay in the NICU, the parents are also worried how would be the baby's outcome. Would the
Yeah.
baby have some sort of a developmental issue? Would the baby
Yeah.
be walking normally? Would the baby be like any other child, go to school or no? So these are certain issues that parents do, ask us commonly. So that is where we come up with the, concept of developmental supportive care, and
Yeah.
also that you start helping the baby in the NICU itself to develop and to have less stress even during their stay in the NICU. And also, we start doing, checks at 6 weeks and 3 months, 6 months, 1 year, where we check the milestones which the baby is supposed to attain at a certain age and see if the baby is attaining these milestones or no. So this is
Yeah.
what we generally look for when the baby comes for a development check. So these are the
Okay.
common issues the parents are concerned with, especially because of a preterm birth.
Yeah. Also, I suppose they would ask you how they can be, personally, physically involved. So, what is it that a parent can do in the NICU when their baby is there?
Yes, definitely. It is difficult because you want to stay there next to the baby, but you can't do anything. So this
Yeah.
is another question where parents want to involve in the baby's care. So what we do is that in general the parents should be involved after a certain stage. In the beginning, The parents need to, come for the counseling, be there, understand what's wrong with the baby, see what is the plan, agree with the plan. If the doctor is giving some options, go ahead and decide and discuss with the doctors what is the next step that is planned for the baby. Understand the reports, see what is going on. After that, it comes the role where mother needs to start giving milk for the baby. So after the first 5 hours, once the mother, in case she's got an anesthesia, she's recovering. So after that, we have a lactation consultant who would go around, and speak to the mother. And you know that Dr. Aruna is the top lactation consultant, and so she would be the best person to advise you all. So the best thing is that at birth itself, or even before birth, if we start sensitizing mother about the importance of colostrum and breastfeeding or breast milk, even in case of a preterm baby, is, that is going to help the baby a lot. So even when we say that nutrition would be given in the form of IV fluids, but it's not just that. We would be starting little bit of milk to be painted in the mouth, just a
Yeah.
few drops of milk, which would give the baby some antibodies, not just for nutrition, but a lot of other benefits of colostrum also. So that's the first,
Yeah.
we call it the liquid gold, or the first vaccine
Yeah.
which the babies get. So this is how, the mother can help in the first few days. Say once the baby is a little stable, that it's off kind of ventilator, and the baby is on a non-invasive breathing support, that's when we start getting the mother to, or even the father, to start coming and doing some kangaroo mother care, wherein they
Okay.
can hold the baby directly onto the chest, and then that helps the baby to gain weight better, to breathe better. So all of these benefits are seen. Later on, we help, the mother is involved in, learning how to feed, how to, give medicines if required for the baby, and then gradually transitioning to, taking care of the baby by herself. So by the
Yeah.
time she leaves the ICU, she should be confident to take care of her baby on her own. So that would be
Okay.
the whole point. Yeah.
Okay. Suppose for some reason the mother is not able to give her milk,
Yeah.
what do you opt for then?
So there are instances where we are not able to start feed because mother is not yet started lactating, or the milk that we want to give the baby is less compared to, mother's milk is less compared to what we require for the baby. In these situations, we prefer to give donor milk. So
Okay.
nowadays we have something which is called as like a donor milk bank. So how you
Hmm.
have blood banks where people donate blood, the same way women can donate milk, and this milk is then pasteurized, checked for infections, and then kept ready in 50 ml kind of bottles, which are then used for babies like who have surgery, or whose mother doesn't have milk, or is extremely preterm. So in those situations, we use the donor mother milk. Now,
Okay.
yeah, so we generally avoid using formula unless, we do not have the donor milk available at all.
Hmm. Okay.
So in
So,
some situations, then in the next step, if it's been long and mother still doesn't have, only in those cases there where, we know that we are, helpless in this situation, that we need to go for formula, but we generally discourage it.
okay.
Yeah.
So, when the baby is in the NICU, say for a 8 week stay, so it's
Yeah.
not just you and your team of doctors and your nurses, but I'm sure many other professionals are also involved. Can you just
Yes.
talk a little about that?
Yes, so the NICU care involves a whole lot of people. So there is a team which involves, apart from nurses and doctors, there's a team of lactational counselors. There is a team of physiotherapists. So they deal with, actively mobilizing, doing some passive movements for the baby. There is a team of developmental team, which is led by a developmental pediatrician. There are also psychologists who are available, because this is a very difficult time. So initial
Yeah.
few days for the parents to see and understand that the baby is going through such a big trouble, it takes time for them to, absorb this whole case, and understand that the baby needs to be in the NICU, and that is why a lot of counseling is required. So we also have the NICU coordinator who's there. Along with it, we have the team of eye examination team is there, which is of
Yeah.
ophthalmologists. So they would be dealing with, checking the baby's eyes and how it is developing. There is a team of surgeons in case the baby requires any of this support. There is a biomedical team, so you require a lot of, machines into the NICU. So these machines need to be and equipment needs to be functioning. You need to calibrate them, make sure that everything is, correct, that you use for the babies. So all of these are required. There is a radiologist who's supposed to be there, and there is also a radiology technician to take X-rays around the corner whenever required. So a lot of people are required to take care of a little baby in the NICU.
So it's a lot of team effort. And
Yes,
I can imagine that it's pretty stressful for the whole team, especially when there are so many babies almost all in the same shape.
yes.
So for the parents, you offer psychological, some kind of de-stressing. What is it that the team does? What do you guys do, your nurses, your staff?
Yeah, so basically, the doctors counsel the parents minimum once a day in detail, where we sit down with the parents, ideally both the parents, if mother can come and if she's, all right to come to the ICU if her health permits. So we sit across and we discuss all the events of the previous day, update them what is the condition and how the baby's condition is progressing. Now, apart from that, we also counsel them daily that, yes, it's a difficult journey, and based on, the duration that the baby needs to stay, the support is also required. Apart from this, our psychologists or our counselors are there who would be, talking to them and try and understand what are their concerns and try and alleviate their fears. Keep on talking to them how about kangaroo mother care and how they can be involved in the baby's care, and trying to tell them about the positives in a difficult situation like this. So there is a lot of things that, required to be done in the first few days. After a while, the parents get adjusted to this whole situation, and that is when things become a little easy, and they, get to understand, and they also form a routine where they come and, come see the baby, get the milk express and give it for the baby, do some kangaroo mother care, and, take a break, read some book, and again come back after a break. So then it becomes kind of a routine, but the first few days are really difficult for them.
Mm, yeah. So, how do you know that a baby who's been there in your NICU for say about 8 weeks is now fit to go home? So, what do you look for?
Yeah, so in general, a baby who's able to feed at the breast directly or able to take feed through the palada, that is a beak-shaped kind of spoon which we encourage in the NICUs, and we do not, generally entertain bottle feeding. So we give the palada feeding. So generally, if the baby is feeding well, mother is confident to feed the baby. If the baby has at least crossed around 1.5 kgs of weight,
Okay.
generally to achieve this weight, it would be around 34, 35 weeks. And if there is no respiratory support that the baby is on. So this is kind of a rough criteria that, the baby can be out of the NICU. There are certain other indications like the baby may be a little small but is stable and its growth has been, less from the beginning. So there may be certain cases where we may have a decision to shift out a little earlier. But in general, 1.5 kgs, we know that, it takes a baby that much time and weight to manage outside the ICU. the baby should be also able to maintain its body temperature without
Yeah.
having the warmer. So in the NICU, we use the incubator in the beginning, and later we use the warmer, the radiant warmer. So without those two, with just a layer of clothes and two wraps, the baby should be able to maintain its own temperature. And the oxygen levels should not be fluctuating, the heart rate should be fine. These are all the conditions, that preconditions that will, only when they are all satisfied do we shift the baby out of the NICU.
And do they go straight home, or is there like a transition period? What happens?
No, so what we generally advise is we have one NICU nurse to be with the mother for 24 to 48 hours, so that she learns, she gets trained into the care of the baby, and also that she has some support, because the NICU
Yeah.
nurse who's been taking care of the baby is available bedside with the baby and the mother, and so that also provides an extra layer of support for mom. And once she's okay, she's confident, and she doesn't require an additional support, then we shift to the regular ward, where only doctors, nurses come in once in 6 hours or so and just have a look at the baby, examine the baby, and go. So, next step is going to ward and then discharging home.
And once they're home, I think it's regular checkups back with you.
Yes, so based on the baby's condition, we decide how frequently the baby needs to be seen in the ICU. So, in the
Okay.
initial period, if the baby was, say, a 26-weeker, like you mentioned earlier, so the 26-weeker getting discharged, we would call for follow-up once in 3 days, even after discharge.
Mm. Okay. All right. So this is the kind of support you give babies who are born in the hospital. Is there something you do for babies who are born elsewhere?
Yeah, so babies who are born elsewhere, so we do get a lot of referrals for babies who are born at other places, and we do retrieve these babies from
Okay.
other hospitals. So we have a team of transport nurses and doctors who would go and retrieve these babies from other states, other districts, and get them to the NICU. Basically, these babies are referred from their city or town to Bangalore, because these facilities are not available in all the
Okay.
places. So
Okay.
managing a preterm is not everyone's cup of tea, and not every pediatrician can do it, because of requirement of a big team, requirement of infrastructure, equipment, and a lot goes into take care of such babies. So,
Yeah.
the thing we do differently is that yes, we may have to transfer these babies. In some instances, we do get a referral where the doctor has told us that the mother is, getting into labor,
Ah.
but she's in the early stages. So we may do a in utero transfer where the baby is not been born, but there is a risk that the delivery may happen anytime. So we have even retrieved the baby while the with the mother. I mean, in utero, the baby is still not born. So these are the things that we do for babies who are born elsewhere and then coming to our hospital. So even at discharge, what we do is these babies, once they're say coming from far off, what we would advise is that the baby should be able to go back to their hospital from where they were referred, so that the baby can spend few days, and the local the local doctor there can help with establishing the feeds there.
Okay.
Sometimes because the mothers do not want to come to Bangalore, or they do not feel it comfortable to travel. So in these instances, once the baby is stable, we transfer the baby back to the hospital, and there the feeding is established. So these
Okay.
are the two things that we do differently for babies who are born elsewhere, or we may refer the baby back for, say, continuation of some antibiotics in those instances.
All right. And I think you've been on some very adventurous air transfers also. You want to talk about that?
Oh, yeah. So, neonatal transfers and air transfer is something where we all are, have an expertise in. So, we were the first team to start, the neonatal air transfers in India, like an official team to do that. And we do the neonatal and pediatric transfers. transfers within India, where we've transferred babies from Pune to Hyderabad, Hyderabad to Goa. Goa to Hyderabad. So these are different examples, or Bhubaneswar to Hyderabad, different transfers that we have undertaken. We've also done transfers from, say, Middle East countries like Dubai. So Dubai to India for a heart surgery. So these are the cases that we have done. So basically, why this is challenging is because you are doing actually three mini transfers. So it is very difficult.
Mm.
So first transport is when the baby from the referral hospital gets into the aircraft by a road ambulance. Then second phase of the transfer is in the air or in the aircraft. And third transfer is from the airport back to the place where baby is going to reach, or the place where it has to go. So it is very challenging because the physiology in air, road, everything is
Yeah.
different. And while you're up in the air, believe me, you have no help. So you're all alone, and that is a pretty scary situation. But
Yeah.
yeah, so we try to, do everything just before leaving, make sure, we do double checks and ensure that the baby should be, transferred safely. So we have developed an expertise where our doctors and team of nurses do even long distance transfers. In fact, one of my colleague has even transferred a baby from, Canada, from Dubai to Canada, and I think it's the longest
Wow.
transfer that we've
Mm.
undertaken till now. So yeah, these things are happening even in India. It's new, but yeah, I think if the government would come up with, some sort of insurance or so, then we would be even able to have the, more people getting the support at adequate time. So where you
Yeah.
can, where a facility is not available in a town, or where the baby needs emergency care, but the baby is, not able to reach because it's too far. So in those
Yeah.
instances, air transfer would be really useful.
Mm. And very life-saving, I suppose.
Yes, yes, definitely.
Mm. So you've been a neonatologist for quite a few years, Deepa.
Yeah.
Is there any preterm baby or a family that stays in your memory, and can you share the reason why?
Yeah, so I remember this couple who had, delivered a set of preterm babies at 30 weeks. And believe me, how the baby did have a stomy. I mean, one of the twins especially had a stomy course in the NICU, but they never gave up hope. And in fact, they would keep on reinforcing and telling us that, go ahead, do whatever is required, and, we are there to support you. And, they were just, their positivity was so good that, it would drive us to do things even better. So when,
Mm.
these are very rare situations that we do
Yeah.
find, because most of the situations are when we are so much into bound by the emotions that, it is difficult to see and these challenges. But this dad and mom, they would be like calm and composed, and they were like, always being so positive with, and not just say one doctor, the whole team. So these
Mm.
are some parents, who would definitely be there in our memory always. But all our
That-
NICU babies are special and very close to our heart. I'm sure you agree, Aru.
I
Yeah,
know, I know. They're all
yeah,
wonderful.
yeah,
So, one last question for you. What
yeah.
is that one thing that you wish all your preterm parents would know? What is that one wisdom you want to share with them?
Yeah, so I think that one wisdom would be like, that our babies are fighting. These tiny warriors, do not underestimate them. I think that they are tiny, but they are mighty and they are strong.
Yeah.
So I think that when these babies are fighting the battle there, we are nobody there to, complain or, have
Yeah.
grudges or have, understand that, okay, why did this happen to me? So all I say is
Mm.
look at the baby every day, how
Yeah.
many ever times we've drawn blood, we've done, so many procedures, but the baby always sees you the next day on your rounds with a smile. So I think there is so much to learn from these babies, that,
Yeah.
they don't hold grudges, they do not have any negative feelings, how much ever, they are going through, but they're patiently there and, trying to hang in there, while they're even being ventilated, etc. So I think that we should not underestimate these preterm babies, just seeing that they are so small and tiny, but they are warriors. So we need to support them and ensure that, we support them too. So, go
Yeah.
there and be positive and give them all the positive vibes that you can, to help them
Mm.
heal and, come out of the NICU quickly.
That is such a wonderful thought.
Mm.
So, is there anything else you would like to say, Deepa? Because I've reached the end of my questions. Is there anything else you want to share?
No, I guess that would be it. I think,
Okay.
if there are any queries, any questions, I think, we could, answer them even later on. I
Yeah.
would be happy
Yeah.
to help any parent or any mother who's having a preterm baby, for sure,
Yeah.
anytime. Yeah.
Okay. So, this was a lovely conversation. Thank you so much for making time to be here with us, Deepa. And thank you,
Sure.
everyone, for
Welcome.
listening. Bye. Thank you.
Yeah. Bye. Bye.